dear colleagues here and everywhere online. My presentation is really, so the base of this presentation was made during the round table due to Thierry and Jordi, because we started speaking about the bacteria which are multi-resistant. But anyway, we started to speak about bacteria, and the aspect of this presentation is going to be from the point of view of bacteria and fungal infections. Of course, I will have to mention viruses, but not COVID, so it's going to be a COVID-free presentation this time. So, we are microbiologists, most of us here, or I don't know, I'm sorry, or infectologists. So our main profession is searching for pathogens. And the first question is always, if there is an infectious case, what type of pathogens belong to the group of pathogens we look for? Well, the beauty and the base of our profession, who are bacteriologists, culturing, we love the colors, the smells, the beautiful colony morphology. We have different types of culture medias, biochemical reactions for the identification, and at the end we have the antibiotic susceptibility testing, what we can read with our native eyes. These are the traditional techniques, quite useful still, and as a framework of my presentation I have to underline, even at the beginning, that we always go back to the traditional methods at the end. But the problem is that it requires pure culture and takes time, so many hours, many days. Well, microscopy looks quite rapid, and in some cases it is rapid enough, because if we look for example, parasites, helminths actually, and we see this picture, we know that's Enterobius vermicularis, we don't have to go on. Or if we have a patient from a tropical country with fever, and after 8 days, and we have this picture, we can be sure it's Plasmodium falciparum, so we don't have to go on. We can be quite suspicious if the clinical case is like tuberculosis and we have this picture, but we need some further investigations to make sure. But many times, if we see these pictures on the microscope, we have to go on. So it's rapid and give us informations, but not very punctual informations. Well, the fact is that roughly 50% of antibiotic treatment are started with wrong antibiotics, and we don't know exactly the name of the pathogen. And okay, we speak about resistant pathogens, but we all know who work with patients that there is a first drug of choice, that even if the bacterium is not a multi-resistant one, there is a first drug of choice. And the problem with the resistant ones, that the first drug of choice doesn't work. So we have to know the name of the pathogen. And of course we know that every hour of delay have an increase in mortality. So the purpose is personalized medicine, using the right drug for the indicated person at the right time, and that is why we are here for these 2 days. Well, we have already mentioned those bacteria which, if we identify, we have to be aware of their resistancy. I don't want to read them up. We all know about them, and we all know the problems they cause. And Jordi mentioned the WHO, and I mentioned the CDC. Of course, the same bacteria are the problematic ones: the carbapenem-resistant Enterobacterales, the carbapenem-resistant Acinetobacter, and we have a lot of problem with that in my hospital, not just here in Barcelona. They are the urgent threats, and the serious threats are the ESBL producer Enterobacterales and the multi-drug resistant Pseudomonas aeruginosa. Well, there are several studies showing us the problem with the not right timing, with the adequate antibiotic treatment. For example, if the bacterium is an ESBL producer and there is a bloodstream infection caused by it, the mortality rate is quite high. Of course, the same with the carbapenem-resistant Enterobacter MRSA, the VRE, also very important pathogens, cause us a lot of problems. So what we need is a quick, sensitive and specific technology or equipment, but it should be also simple and affordable. Well, at present, there is a significant change in microbiology, both in the identification and resistance testing. There are wonderful technological advances in the molecular techniques. MALDI-TOF is, I think, quite widely available in at least big laboratories all over in Europe. As I remember, Thierry also mentioned the importance of the phenotypic quick resistance testing. We have a method, this Accelerate Pheno system, which is good for ID, but also it can give us phenotypic antibiotic susceptibility testing result. There is a promising technology, the MARY AST, which is a rapid phenotypic examination directly from sample, ID and phenotypic AST. And a very expensive but also a helpful new technology is this T2 magnetic resonance technology for ID and detection of resistance markers directly from sample. Well, advantages of rapid tests: quick identification, resistance markers, sometimes even phenotypic antimicrobial susceptibility, even directly from sample or from the culture. A very important advantage is the detection of non-culturable pathogens, and of course there is a very good impact on the patient hospital stay, and also so on the outcomes of the patient and of course the whole thing together. Well, what is the disadvantage? Well, if it's for example a molecular technique, we will get the result only about those pathogens which are included in the panel. Sometimes they are very expensive to implement, sometimes they need special training, and also the interpretation is complicated, so the viability of detecting the gene is hard, and also it cannot differentiate between colonization or infection. And again, it will require concurrent conventional identification and antimicrobial susceptibility testing, so we just cannot rely on the result of a new technology. And also a very important impact, a very important disadvantage. So it has to have a very good antimicrobial stewardship program in the hospital to have the real advantage of these new techniques. So before we try to make an implementation of a new test, we have to think over our local epidemiological data. For example, in my hospital, due to this COVID, there is a very high number of VRE infections. Not always infections, but many times even blood culture positivity. But colonization has a very high level. We have to see if we have the antimicrobial stewardship program in our hospital. How can we rapidly communicate the result? And we have to have an appropriate adjustment of antimicrobial therapy. there is an article about the impact of these rapid tests on cost effectiveness. And of course, if there is an antimicrobial stewardship program in the hospital, there was an 80% chance of cost effectiveness, without it only 41. So, of course. Now, sepsis. The cornerstone of the diagnosis of sepsis is still blood culture, because that is the prerequisite of the antimicrobial susceptibility testing. But of course, it takes time, and we need rapid diagnosis, because 80% of sepsis death could be prevented with rapid diagnostic methods. And identification and antimicrobial sensitivity. The traditional way, as I mentioned, a few days. But identification and resistance markers can be directly detected from positive bottle. I mentioned MALDI-TOF, which works with peptides, and there are many, even more than I just mentioned here, molecular biological technology. These methods provide actionable information much earlier with a very high positive predictive value, but the problem is that only for on-panel targets. For example, it was just an example from my lab. We just changed a few months ago from panel 1 to panel 2 with this BioFire film array blood culture method. And the first patient, in the case of the first patient, we couldn't have the result Cryptococcus neoformans, though it was in his blood. In the second patient, we could make it sure on the very, very first day after the gram-stained smear. Well, the Accelerate Pheno system can give us a rapid identification and phenotypic AST directly from positive blood culture. Not from blood yet, but at least from the positive blood culture in a few hours. So we don't have to wait 24 hours. The result is ready after 7 hours. The ID uses FISH technology and MIC for the antibiotic susceptibility testing. The sensitivity, specificity, and agreement with the conventional method was very high, but again, nothing is 100% positive. No ID and antibiotic susceptibility testing for gram positive rods, and no antibiotic susceptibility testing for yeast. So, not perfect, of course. A wonderful system with the identification is done with fluorescence, in situ hybridization, and MIC. This system lacks resistant gene testing, but there was a study in which they prove that ESBL production has a high likelihood of ceftriaxone non-susceptibility. I wanted to emphasize that it needs the pre-culturing of the blood culture, so it doesn't work from the blood. The SMERI AST, it's a new technology. I don't know how many places. I tried to find some articles on it, but I couldn't. But it's a promising technology because it also works directly from samples and even polymicrobial samples. It's a fluoroimmunoassay which makes an ID in 20 minutes, and also MIC method, so antibiotic susceptibility testing also. So there is a phenotypic antimicrobial susceptibility directly from the sample, even polymicrobial, and very easy to use, so it can be used as a point of care method. Must be very expensive. Another very expensive possibility, but now it's a culture-independent molecular diagnostic method. This T2 magnetic resonance examination, ID in 4 hours. And the positivity rate of blood cultures are much higher than just the normal culturing. This T2 magnetic resonance panel, which works directly from blood, so we don't need the pre-culturing, has Candida panel, bacterial panel, and also can detect resistance genes. But again, I would like to emphasize something. Thierry has also, I think he mentioned, not Jordi, but it doesn't matter. So, but we all know that if you detect a resistance gene, it doesn't mean that your pathogen is the one which holds that resistance genes. And the result is controversial. But anyway, it can detect resistance genes also. The Candida panel is quite good if we think about the most typical infectious Candida, albicans and non-albicans genus and species. The bacterial panel contains only 5 bacteria, but those ones which are very typical in serious infections in ICUs, and these ones were mentioned when we mentioned those escape bacteria. Well, the T-catter, sorry, that's in Hungarian. So the T2 bacteria panel is limited only to 5 bacteria. The negative predictive value is very high, but only for the 5 pathogens, of course. The advantage is that it can detect more positive cases than the normal original cultivation method, but again the gene is detected and you don't know exactly if it was true positive or not. Altogether, in one study, it covered 7.5% of all species detected by blood culture. Mainly the problem with the non-positivity of blood culture was that the bacteria was in a closed space, or there was a localized infections like abscess, pyelonephritis, or some other possibilities. Well, the main, for me, as I went through the literature, candidemia was the main advantage of this new method, because candidemia is not an easy diagnosis. The negative predictive value was very high, so this method can reduce times to appropriate antifungal therapy. And save, of course, money because of this. And, of course, the length of stay reduction is also an important fact. In a study, it can identify in 93% of patients after the implementation of T2MR, the Candida species. Sorry, somehow my pictures went somewhere else where it were before, but it doesn't matter. But after can be read, I think. And if you compare it, the era before using this T2MR, it was only 57% of patients who had a positive result. But of course, doctors cannot rely only on something which is not traditional. So 36% of patients' antifungal regimens were not discontinued despite a negative T2 result. But the therapy was avoided in 23%, and the initiation was in 41% of patients. The reason why physicians do not rely on this result so easily, that in deep-seated invasive candidiasis, the positivity rate was not so good. So the antifungal de-escalation is controversial. Well, invasive candidiasis is a big problem because the mortality rate is 60% in case of septic shock, and not all the labs in the world can afford T2MR. So we have to have something else because yes, we need to do something with our patients. Well, blood culture is far from being ideal because it's a few days. So we have to look for some other signals, and especially in intra-abdominal candidiasis, the positivity rate is even worse, and that results in the overuse of empiric antifungal therapy. The beta-D-glucan test, I think it is something everywhere quite useful. It uses the clotting pathway, and because the beta-D-glucan is a component of the cell wall in many species, but some are missing, like Mucorales and also the Cryptococcus neoformans, which is very not so frequent, but definite infectious agent in HIV patients and our neutropenic patients. But in pneumocystis infections, which were not easy to find, the sensitivity rate and the negative predictive value is very high. So beta-D-glucan has a very important impact on the diagnosis of pneumocystis infection. Sorry, again, the arrow is somewhere else, but the arrow and this, it was together somehow at home in Budapest. Anyway, there are some, of course, cross-reactivities and false negativity. I don't want to go into the details. Aspergillus antigen detection, again, something quick and not so expensive, but the problem is low sensitivity, so we need serial testing. The sensitivity was around 50%. Well, Carius test, something new and very expensive. It's a non-invasive blood test, uses next generation sequencing. The idea behind is that pathogens leave traces of genomic DNA in blood. It can identify different types of infections and detecting lots of types of bacteria and DNA, viruses and fungi, mold and yeast and parasites. For example, if we compare it from the point of view of Legionella, 33 Legionella species are detected. If we use the urinary antigen test, which is much cheaper, but to be honest, quite useful in the everyday work, because that is the most typical causative agent. There is only one species, and in that species, one serotype. I just try to rush, so I will not read up this story of the scientific officer of Carius, but it was a very nice story of a small child who had Klebsiella pneumoniae detected by blood culture, and cefepime therapy cleared the fever away, but the fever came back, blood cultures and even PCR tests were negative, and then Carius test detected Rhizopus oryzae. We all know microbiologists that that's a hard diagnosis and doesn't take a few hours, but in this case, the timing was great and the patient received targeted therapy and recovered. Well, again, I don't know what happened, but the liquid biopsy was somewhere in between the two lines. So in deep infections, there is a very important advantage of this technique, because many diagnostic biopsies can be avoided, and in hematological patients we all know that it's very hard to do biopsies because of their problem of the clotting pathways with the thrombocythemia. So they don't have thrombocytes. So in invasive mold infections, this liquid biopsy had a sensitivity of 51%. It's not very high, but to be honest, not bad comparing it to the normal way. But if we do it together with the galactomannan test, which sensitivity alone was around 51, it could raise up the sensitivity to 84%. There is another story about knee and hip periprosthetic joint infections, where they compared the intraoperative normal cultures with this next generation sequencing technique, and together again there was a rise in the detection rate of the two systems together. And what is quite important, 14 additional organisms were detected by next generation sequencing. Well, just a quick rush through the respiratory infections. Absolutely overuse of antibiotics, because the distinguishing between bacterial and viral etiologies are not so well diagnosed. The first step could be the procalcitonin-guided therapy, which is a help, but specificity and sensitivity are too low. There were many tests, these lateral flow tests, but in these cases we have to know exactly what we are looking for. Streptococcus pyogenes, Legionella, Streptococcus pneumoniae with not a very high sensitivity, but these are not expensive tests, but that is the only thing which is examined in these cases. So I would love to jump to the multiplex PCR technology. Well, most of the infections, respiratory infections, are caused of viruses. I mean the upper respiratory tract infections. And in these cases, quite important not to use antibiotics. So, we have very good multiplex PCR respiratory panels, which can give us very good and quite quick results. And again, I would like to underline something apart from the advantages, that in the case of pneumocystis, the sensitivity of these PCR methods 100 times more sensitive than microscopy. It was a very hard diagnosis before these PCR possibilities. Well, even though we have the multiplex respiratory PCR panels, which can give us the information of the causative agent, we shouldn't forget about the initial gram stain smear. So again, back to the traditional way. They found in a study a very good correlation between the initial gram stain and the result of the multiplex respiratory PCR panels result. So when there is a positive result, we have to accept it with caution. And again, it is written on this slide what I have already said, that if there is a detected, for example, CTXM positivity or anything, it doesn't mean that it belongs to our pathogen. So panel results should be used with culture results to confirm susceptibility and resistance. It's also, again, okay, just I have, I think, 3 or something more. So, for example, the surveillance, the MRSA surveillance also is a great help, of course, from public health considerations, but also it can give us a very high negative, positive predictive value if there is an ICU and pneumonia, and we think it could be MRSA. The negative predictive value is high if it's negative, and it keeps the result for 7 days. The last, almost the last, what is it? Slide. Yeah, thank you. Central nervous system. We all know that. I don't want to go on with this, because we had the latex agglutination. Oh, actually, in this case, the good old gram staining was very, very useful. And the latex agglutination test is also quite good, but the BioFire quick and accurate. So gold standard is still culturing for several reasons. The rapid diagnostic test give us a better, much better approach to infections. Antigen test can be used as point-of-care diagnostic method. The nucleic acid amplification tests are wonderful, but before accepting the result, we have to take it into a sober consideration. If we do two things together or more, adds a special value, but without antimicrobial stewardship program, the value of the rapid diagnostic tests is much less. So this is the last one. Future is a blooming flower, is like a blooming flowers, continuous development, promising and more accurate results and better timing, but we should never forget the value of the traditions. So traditional and new technology, let's keep in touch. And thank you very much for your attention.